thing I want to talk to you about are these stages of sleep that we all stages of non-REM sleep. So stages 1 and 2 we consider light non-REM sleep. 3 and 4 are deep slow wave sleep or deeper stages of non-REM sleep or slow wave sleep. We'll keep coming back to this as the talk goes on. Parasomnia, the word itself is a hybrid of the Greek para, alongside of, and the Latin somnus, or sleep. So these are events that accompany sleep. Well, to be more precise, parasomnia is pleasant, undesirable, or experiential phenomena occurring at sleep onset, within sleep, or during arousals from sleep. Arousals are brief brain awakenings. That's what it means. As a sleep specialist, we think of 3 states of consciousness. There's wakefulness, non-REM sleep, REM sleep. This is a brief overview of the neurochemistry and neuroanatomy behind these stages here. So in wakefulness, you have relative elevation of certain neurotransmitters. 5-HT, dopamine, norepinephrine, these are increased. There is a part of our brain, deep within our brain, in the brain stem, called the ascending reticular activating system. This controls awakeness. If you have a problem in this area, you're going to have a situation like Terry Schiavo, where there's no real consciousness. This works in conjunction with the dorsal raphe nucleus and the locus coeruleus, as well as the cortex, which is the outer layer of the brain, to promote awakeness. During non-REM sleep, interleukin-1 beta is increased. A neurotransmitter called GABA works on 4 brain neurons. These are in the front of the brain. And there's a role of histamine and adenosine here. Now, as you probably know, antihistamine medications tend to make you drowsy. Some people use them for sleep, things like Benadryl. Adenosine, interestingly enough, this is what caffeine works on. Caffeine inhibits adenosine to promote awakeness. You can think of many parasomnias as an inappropriate overlap between wakefulness and non-REM or REM sleep. These are images from PET scans. PET scans show metabolism. Okay, this is actually based on blood flow. This shows how active different parts of the brain are. What you can see here, the top one, this is during wakefulness, is a lot of yellow, red, orange colors. What does that mean? Yellow through red, that spectrum means high metabolism or high activity. Okay? So particularly active here, you see frontal areas of the brain, frontal lobes. Okay? And what I want you to really pay attention to is what changes when we go to non-REM sleep. Non-REM sleep, you see all of a sudden the color changes. It's purples, blues. This is decrease in metabolism. So the brain sort of dials down its activity. But lo and behold, during REM sleep, it fires up again. You have a lot of activity. Okay, the brain is very active during REM sleep. Particularly active are parts of the brain involved in processing sensory information. So visual, auditory processing pathways, these are really active here. And that makes sense because we're having a lot of vivid dreams, right? So the first group of parasomnias we're going to talk about are those that occur in wakefulness or the sleep-wake transition. We're talking about restless leg syndrome. We're going to talk about hypnic jerks, which are also known as sleep starts. We're going to talk about sleep-related rhythmic movement disorder. Restless leg syndrome. So, any Seinfeld fans here? Okay. Classic episode. Kramer's complaining about a girl he's dating because she has the Jimmy legs. Okay, he can't get any sleep. So people call this by all different names, lay people. But what people describe, it can be hard for them to put into words. They usually say something like creepy, crawly sensations on the legs, ants on the legs, or an itching feeling in the legs. Diagnostic criteria are these uncomfortable feelings in the legs with an urge to move them around. Symptoms are worse in sedentary situations. Symptoms improve with movement. Symptoms are worse or limited to occurring in the evening or night. Now, children often have a little bit different presentation. They'll complain of growing pains. That's actually a common way for children to express the symptoms of restless leg syndrome. This problem can lead to trouble getting to sleep and staying asleep. Treatments include checking iron levels in the blood, and if they're low, we often start with iron supplementation first. We use medications that work on the dopamine and GABA systems. These are the motor systems of the brain. And we look hard at any precipitating factors like caffeine or other medications that can bring out restless legs. There may be a role in exercise. So hypnic jerks. These are sudden, brief, simultaneous contractions of one or more body segments that occur at sleep onset. They're very frequently associated with a sense of falling, but people can get other sensations too. They often occur singularly, or sometimes they occur in multiple in a row. Has anyone had this before? Raise your hand. Okay. Yeah, that's about right. So 60 to 70% of all people will experience this at some point. All ages, both sexes affected equally. There are usually no complications, but it can, in rare cases, lead to sleep onset insomnia. Generally, treatment, if needed, is aimed at reducing predisposing factors. Usually look at whether people are taking too much caffeine or other stimulants, and these are more common after very intense physical work or exercise, can be more common in emotional stress situations. Sleep-related rhythmic movement disorder. These are repetitive, stereotyped, and rhythmic motor behaviors that are not tremors. They occur predominantly during drowsiness or sleep and involve large muscle groups. There has to be significant clinical consequences to make this a disorder. So what we're talking about is interference with normal sleep, significant impairment in daytime function, self-inflicted bodily injury that requires medical treatment. Although interestingly, there's little risk of serious injury in these behaviors. You're going to see some videos and you're going to think they look pretty bad probably, but to be honest, it's very benign in most cases. Most of these patients are brought to medical attention because the family is so disturbed by what they're hearing and seeing. So what are the subtypes of rhythmic movement disorder, which is called RMD in the field? So body rocking, head banging is the most notorious and well-known type of this. It's also sometimes referred to by its Latin name, jactatio capitis nocturna. Head rolling, less commonly body rolling, leg banging, leg rolling. Here's a picture of Beavis and Butthead showing some head banging. So in order to use the mouse to click on the video, great. This is not PowerPoint 2007. Should we reconnect to?
We'll have a quick solution here.
This is like the best part of the. We got to make this happen for you. So.
All right, so your video out. Yeah.
Did you embed the video, Joe? How did you put the video
Oh,
in
you know
there?
what? That may be. It's because it's the link.
You've got to embed the link essentially.
Ah.
Do you
Yeah.
have the
Is
link?
this a video? Is this
Well,
a
it's on my computer.
Okay,
Can you?
then we can do that.
Does this have sound, the video?
Yeah.
Show?
Yeah.
Where's your video, your sound out?
Right over here. Okay, sorry.
Yes. Okay.
Well, that was the problem.
Find the links.
Oh, that's right. We can do it. No. To
Four. Yeah.
control it.
Function. Yeah.
Just hit escape. You're trying to get out of that.
There we go. It's switching. Right. Yeah, we do one more, then you'll see it here as well. Right.
Okay. Good news.
There's a switch back here. We can flip it. You can flip back and forth. We can see the laptop.
Okay. Not to fear. Everything's okay. So, this is head banging. I want you to notice he's laying prone on the bed, hitting his head against his forearm. So,
Press the PC button. Now you're going to be back. We're there. Now you can just go back.
oh, I can just keep it like
work
that's
it out
fine.
there?
Yeah. These are actually fairly common. About 60% of infants at 9 months will have one or more of these movements. It declines over time. There's no sex difference, and there can be a familial pattern. Why do people do this? Well, there are theories about this, that maybe it's a soothing effect on the vestibular system, which is the inner ear, sort of similar to like rocking a baby, something like that. Perhaps it's an effect of environmental stress or lack of environmental stimulation. Some children, say with like autism, do these sorts of things as self-stimulating behavior. Some people have suggested that could be attention-getting or passive-aggressive behavior. So moving on to parasomnias that occur in light non-REM sleep, we're going to talk about sleep-related bruxism, somniloquy or sleep talking, and periodic limb movement disorder. Sleep-related bruxism. This is oral activity characterized by grinding or clenching of the teeth during sleep, usually associated with sleep arousals. So there's two types. There's tonic contractions. These are the clenchers, and what's known as rhythmic masticatory muscle activity. These are grinders. Prevalence of 14 to 17% childhood, and it declines in age, with age. I want to show you a little bit about what I look at for half of my day. These are, this is an image from a sleep study. A lot of stuff going on here. These tracings up here, these are EEG leads. These are brain waves that are being recorded here. And then you have some EKG stuff here. There's the heart, then flow, airflow coming through the nose and mouth. And then these down here represent effort, breathing effort. And what you could see if you had amazing vision was a little speeding up of the EEG here. This is a micro arousal. And then it sets off this sort of rhythmic stuff here. This is actually muscle activity from the masseter muscles. These are our big chewing muscles here that is transmitted up into the EEG. It's actually artifactual, so it's erroneous data that is showing up where it shouldn't. This is what bruxism looks like on a sleep study. So why does this happen? Well, there seems to be a relationship between certain psychological characteristics of people, or maybe people predisposed to this. It comes out in times of stress. So some research has found an increased incidence of OCD traits and type A sort of personality, people who have bruxism. And it's also been found that these people have elevated urine catecholamines, and catecholamines are stress hormones. Secondary bruxism can be associated with developmental disabilities, but it's most commonly associated with dental disorders, specifically malocclusion. So this is the teeth not coming together well. There was a famous research study where monkeys had fillings put in that did not allow them to bring their teeth together properly, and they just tended to grind their teeth down until they fit together well again. Also, stimulants like caffeine and cigarettes, especially close to bedtime, can predispose one to this. I have to warn you, this is worse than nails on a chalkboard, okay? Okay. This is a photo of someone who's really done a good job grinding their teeth down. You can see how flat they are. The main complications from this are dental, so wearing of the teeth, broken teeth, oral lesions, cuts, can result in headaches or TMJ pain. It's often an annoyance to bed partners. Possibly it can disrupt sleep. Not so clear about that. Treatment, usually a bite splint, which a dentist makes. Muscle relaxants can be used, stress relief, avoiding stimulants like caffeine, nicotine, and possible role of Botox on those masseter muscles to sort of paralyze them. Sleep talking. So this is very common, defined as speech or sound uttered during sleep without awareness of the behavior. It lasts from seconds to minutes. It becomes a problem when it's loud enough to bother other people. There's a cartoon here. I don't know if you can read this, but it says, it's a mother talking to her son saying, "Sleep tight, don't let the bed bugs record anything incriminating." So this is actually a good scare tactic, but not true, as information that people say when sleep talking usually has very little to do with the truth. It can be spontaneous, or people can elicit it by talking to the sleeper. This can also occur in REM sleep. Tends to have an increased frequency during periods of stress, fever, or disturbed sleep. These are the Rockettes here, and this is what some people do all night long. This is called periodic limb movement disorder. Repetitive leg kicks that disrupt sleep. 80% of patients with restless leg syndrome will have this as well on their sleep studies. Treatments are similar to restless leg syndrome. Here's a video. What I want you to note here is how repetitive and stereotyped these movements are. Stereotype meaning same thing over and over again. This is a classic movement for periodic limb movement. There's dorsiflexion of the foot and flexion at the knee. So a person's going like this. This video is sped up. Moving on to deeper stages of non-REM sleep. These can all sort of be lumped into one category that we call disorders of arousal. They're sort of all on the same spectrum. What we're going to focus on is somnambulism, which is also known as sleepwalking, night terrors, confusional arousals, and a few special cases, including sleep sex, which is a form of confusional arousal, and sleep-related eating disorder. So again, back to our, this is called a hypnogram, by the way. This is a night sleep in a chart form. So what we can see here is, as I said, stages 3 and 4, this is slow wave or very deep sleep. This is the type of sleep that tends to precipitate sleepwalking and related episodes. As you can see, kids have a whole lot of this, and it occurs during the first half of the night predominantly. As we get older, we have less of this, and to the extent that elderly people have very little, if any, slow wave sleep. This is why the incidence of sleepwalking tends to decline with age. So here's another picture of a sleep study. This is a 16-year-old girl who had a confusional arousal. What I want you to see is here, this is the brain waves again. You can see, imagine that these are kind of big waves compared to some of the stuff in here. So these are slow waves. This is what they look like on an EEG. But something happened here. There was a little micro arousal. And here you see that you have some faster frequencies superimposed on these big waves. So you have sort of an overlapping of wakefulness and deep sleep. And that's what sets off these episodes. In this one, the girl sat up, looked very confused, moved her limbs a bit, and then went promptly back to sleep. There's a theory about why certain behaviors are more common during sleepwalking, and it's the basic drive states theory, in that we think during sleepwalking and related behaviors that a primitive part of the brain is activated that causes certain fundamental behaviors that are very ingrained in us to occur. So locomotion, walking, aggressive behaviors, eating, and sexual behaviors. Sleepwalking, the eyes are usually open with a glassy stare. This commonly co-occurs with sleep talking and night terrors. There are seemingly purposeful and goal-directed behaviors, but the behaviors are illogical and unsound or dangerous. The first lecture I had on this from a professor at University of Michigan, speaking of unsound behaviors, he described how he had fallen out of a 3-story window after climbing out of it during a sleepwalking episode. This is as high as, occurs in as high as 17% of children, peaks by the ages 8 to 12, up to 4% of adults have this. There's no sex difference. Higher rates of injury or violence occur in male sleepwalkers. Most children will have spontaneous resolution of this around puberty. Traditionally, there had been felt to be a link with psychopathology and sleepwalking in adults. However, as this has been researched further, there is not a great overlap between psychopathology, so mental illness, and sleepwalking. So we don't really think the two are related, and there's definitely no relationship in children. Risk factors for sleepwalking. I've bolded ones that we commonly identify and address in the sleep clinic. So there are clearly strong genetic factors at play here. 65% concordance in twin studies of sleepwalking. Sleep deprivation. The mechanism here, if you don't get a good night's sleep for a period of time, one night or a period of time, say in finals, and then you get a normal night's sleep, you have a rebound of slow wave sleep, so more than you normally have, and it's a bit unstable, and you can have more of these micro arousals to set you off. There's also stress, alcohol, other drugs. And most importantly, in my sleep clinic, sleep apnea, obstructive sleep apnea, which I'm going to digress about a little bit, and other medical problems. So physicians used to call syphilis the great imitator because it had a myriad of presenting symptoms. It was really hard to diagnose. But in the sleep clinic, I kind of feel like sleep apnea is the great imitator. So many of the sleep disorders that people present with are actually fundamentally caused by sleep apnea. So what is it? It's a type of sleep disordered breathing where the person has excessive partial, which is called a hypopnea, or complete apnea, upper airway obstruction. Associated symptoms include snoring, fatigue, sleepiness, unrefreshing sleep, insomnia, and there are medical consequences to this. For example, high blood pressure, heart disease, stroke. These are cartoons of what's going on with sleep apnea. So here we have a patent upper airway, okay? But here in the patient with sleep apnea, these soft tissues, including the tongue base, soft palate, uvula, fall back and collapse that airway. I want to show you a video of someone with sleep apnea. And what I want you to notice is how they have a characteristic fish mouth sort of appearance. They're breathing, but you're not hearing anything. And then she increases her effort so much that she overcomes the obstruction. You'll hear a lot of snoring. So as you might expect, something like that, the way the person actually overcomes the obstruction is their brain wakes up. So all those brain awakenings can set off sleepwalking and related behaviors. Diagnostic criteria for sleepwalking: ambulation that occurs during sleep, persistence of sleep, an altered state of consciousness or impaired judgment during ambulation demonstrated by at least one of the following: difficulty in arousing the person, mental confusion when awakened from an episode, amnesia, routine behaviors that occur at inappropriate times or places. So an example of this would be my brother in college who had a little bit too much to drink one night. He ended up sleepwalking and urinating in the trash barrel of his dorm room, much to the chagrin of his roommate. Other dangerous or potentially dangerous behaviors can occur, and there have been cases of grievous bodily harm and even homicide that have been attributed to sleepwalking. So this is a famous case from Canada that occurred in 1994 in which a man who was a known sleepwalker drove across the city where he was living and stabbed his mother-in-law to death and gravely injured the father-in-law, and he was acquitted on the basis that this occurred during a sleepwalking episode. Does anyone know what this is? Right, Mooks, the scream. So leading us into our next topic here, I thought it was a fitting painting. Sleep terrors. These are characterized by a sudden episode of terror that occurs during sleep. It's usually initiated by a cry or loud scream that is accompanied by autonomic nervous system and behavioral manifestations of intense fear. Autonomic nervous system being our sympathetic nervous system, our fight or flight response gets activated. Any parents in the room have seen this with their children? Couple? It's very disturbing. And what you will have noticed, the signs of this autonomic nervous system activation are dilated pupils, flushing, elevated heart rate, sweating, looking very fearful. And this is in conjunction with one or more of difficulty in arousing the person, mental confusion when awakened from an episode, amnesia, dangerous or potentially dangerous behaviors. There's often prolonged inconsolability here. And in regards to psychopathology, none in children, but adults have an increased incidence of bipolar disorder and depression and anxiety. However, when the psychiatric disorder is treated, these sleep terrors seem to persist, so it would suggest that there's not a very tight link here. I'm going to show you a video, and this is actually a hybrid of a sleepwalking episode and a night terror. And as I said, they're all sort of related on the same spectrum. Confusional arousals. These are defined as recurrent mental confusion or confusional behavior that occurs during an arousal or awakening from nocturnal sleep or daytime nap. They usually last 15 to 40 minutes. They're often precipitated by forced arousal. So someone coming in, waking the sleeper up can set this off. There are two adult variants: severe morning sleep inertia, which probably a lot of people of the students in this room probably think that they have, which is real difficulty getting out of bed in the morning to the extreme. This actually takes place in lighter stages of non-REM sleep, but for all intents and purposes, it's basically the same thing as a confusional arousal. And then sleep sex. This term was coined by my mentor where I did my neurology residency at Kaiser Permanente in Los Angeles after he published a case series in 1998. And it refers to sexual behaviors that are performed during sleep. And they're typically out of character for the individual. Okay, so one factor is that these behaviors usually are initiated irrespective of the menstrual status of the person or their partner. Behaviors can include vocalizations, masturbation, intercourse, and there have been sexual assaults. So there are medico-legal implications for this. It occurs in men and women. We don't have great data on how frequent it is, but we believe that it's greatly underreported. People just don't like to talk about it or think that it's normal. Sleep-related eating disorder, defined as recurrent episodes of involuntary eating and drinking that occur during the main sleep period. One of the following is present: consumption of peculiar forms or combinations of food or inedible or toxic substances. We're talking raw bacon, we're talking cat food and salt sandwiches, we're talking buttered cigarettes, things like that. Insomnia related to sleep disruption from repeated episodes of eating with complaints of non-restorative sleep, daytime fatigue, or sleepiness. Sleep-related injury, dangerous behaviors performed while in pursuit of food or while cooking food, morning anorexia, so not having appetite or eating in the morning because people have eaten so much during their sleep. Adverse health consequences from recurrent binge eating or high-calorie foods, namely weight gain. This is female predominant, high incidence of concurrent eating disorders. 80% of the time when we do a sleep study on people with this complaint, we find another primary sleep disorder, such as sleepwalking or confusional arousals. This may be medication-induced, for example, Ambien and related medications, but this usually happens. Ambien had got some bad press for a while. People driving and eating and doing all sorts of stuff. This usually is the person's fault for taking it and not going to bed. Okay? Now, sleep-related eating disorder must be distinguished from nocturnal eating syndrome, which is basically, I think of it as an excuse to binge eat. So this is overeating between the evening meal and sleep onset. Eating occurs during complete awakenings from sleep with full subsequent recall. This is much more common in my clinic. absence of bizarre or toxic food and substance ingestion and peculiar eating behaviors, absence of an associated primary sleep disorder. So I put brownies on here because I had one woman who came to see me in clinic who had gotten this habit of eating brownies in her sleep. And what it came to was that her boyfriend baked brownies every night and put them on the nightstand. And during the night, she would sort of reach over and eat them. But when she was really pushed, she had full recall. And this is obviously not a bizarre food to eat. So I actually have a video here of sleepwalking and sleep eating. And I want you guys to analyze this and tell me how accurate of a representation this is from what we've talked about sleepwalking and sleep eating. Little snort, probably has sleep apnea, setting this off. So vocalizations. So strange food, eating raw coffee. Aggressive, potentially dangerous behaviors here with this with a knife.
I don't know where you learned it, but I'm still sore.
Well, there's lots more with that.
My God.
No. What happened? Oh my God.
So surprisingly enough, Hollywood did a fairly good job of depicting sleepwalking and sleep eating there. Treatments, usually we focus first on avoiding precipitating factors. If medications are needed, we use benzodiazepines, for example, Klonopin, as first-line treatment. Safety precautions are important, so this is locking doors, hiding car keys, other things like that. In some instances, psychological or psychiatric treatments are helpful. For sleep-related eating, we usually use this medication called Topamax, which is actually an anti-epileptic medication that has a number of purposes, but it seems to have somewhat of an appetite suppressant side effect. Now, one of the main things in the differential diagnosis for sleepwalking are seizures. It can be hard to distinguish between seizures and parasomnias. I'm going to show you this video here. What I want you to notice is how stereotyped these episodes are. They're very similar. They happen multiple times in this video, and they're very similar, okay?
Che è successo? Che so.
So particularly seizures emanating from the frontal lobes can lead to very complex behavior. So the frontal lobes control motor activity and planning and things like that. We do use a scale called the frontal lobe epilepsy and parasomnia scale, and this is probably way too hard to read, but this helps us distinguish clinically on trying to tell whether something's more likely to be a parasomnia, more likely to be a seizure. So we look at age, duration, stereotypy, timing, things like that. So question for the audience. people ask me this a lot. Should you wake up a sleepwalker? Is it true that it's a bad idea? What do people think? Has anyone seen the whole movie Step Brothers? Raise your hand. Okay, so what happens in the second sleepwalking scene? Yeah, and what happens? You get the father character gets thrown down the stairs. So it is true that sometimes waking a sleepwalker can result in a violent or aggressive outburst. So it's best to gently guide them back to bed. That's the best thing that you can do. So moving on to REM sleep, which stands for rapid eye movement. We're going to talk about REM sleep behavior disorder, known as RBD, nightmare disorder, and cataphrenia, which is sleep groaning. First, I'm going to tell you a little bit about sleep physiology. So this is a slide, a cartoon of an area deep within the brainstem in the pons. And these areas here, this is the pontine tegmentum. And in this area, we have control centers for regulating REM sleep. Okay? I put the cat in here because the seminal experiments that determined and worked out the neuroanatomy of this were performed in cats. If you ever see a photo of a cat, maybe in one of your psychology books with an electrode sticking out of his brain, that's probably from the study. So what normally happens in REM sleep is that we lose our muscle tone. The only thing that's working in REM sleep in terms of muscles is our diaphragm to allow us to breathe and our eye movements. So we achieve a state that's called atonia, or lack of muscle tone. In REM sleep behavior disorder, people lose this shutting off of muscle tone, so they maintain it during their dream sleep. Therefore, they act out their dreams. Okay? So the diagnosis of this is we see this on a sleep study in EMG leads. EMG measures muscle activity. We use chin leads and leads on the extremities. And one or both of sleep-related injurious, potentially injurious or disruptive behaviors by history, abnormal REM sleep behaviors on sleep study. So this is the band REM when Michael Stipe still had hair. They're actually good. Side note is that they randomly selected their name by just opening up a dictionary to a random page and just saw that and said, that sounds good. So RBD can be idiopathic, which also means primary. This is usually associated with neurodegenerative conditions. These conditions fall under the heading of synucleinopathies. So that means Parkinson's disease, related conditions. And then there can be secondary RBD caused by something else. This is usually attributable to medications like antidepressants. And you can have a similar sort of condition in patients who have PTSD. Clinically, bed partners will complain about a lot of limb twitching, and for some reason, the behaviors in RBD are usually violent, defensive ones, or loud vocalizations, swearing. I had one patient who came to see me. He was brought in with his family because he was doing a lot of unusual things in his sleep. He was a pastor at a local church, and they said, we can hear him cussing through the walls. We didn't even think he knew these words. Patients will remember vivid dreams. They usually say they're being attacked by something or defending themselves. Eyes are usually closed, and eyes being closed sets them up for injury. They're not seeing things that they're going to stumble over or run into. So there's a high degree of injury in patients, but also in bed partners who can get kicked and punched. Come back to this again because, just to remind you, there's, as the night goes on, there's more and more REM sleep. So the history we look for is that these events typically will happen in the second half of the night, or at least 90 minutes after sleep onset. Men have a preponderance here, and they're usually over 50. 2/3 of them who are diagnosed with RBD will go on to develop a Parkinsonian disorder. This is also common in narcolepsy. I want you to note the ballistic movements that this patient has. He's defending himself. There's no audio, but he starts out, he's really jawing at someone in his sleep, if you watch his mouth. Yeah, these patients are commonly falling out of their beds. So treatment, we use dopamine agonists, which, if you remember me talking about earlier with restless legs, they work on the motor centers of the brain. Also, melatonin is quite effective. Safety precautions are key, so covering any windows with heavy drapery because people have sort of dived into the window, removing any furniture with sharp corners, and discontinuing any offending medications. Moving on to nightmare disorder. That'll wake you up 3/4 of the way through the lecture here. Our old friend Freddy Krueger. So these are recurrent episodes of awakenings from sleep with recall of intensely disturbing dream mentation, usually involving fear or anxiety, but also anger, sadness, disgust, and other dysphoric emotions. There's full alertness on awakening with little confusion or disorientation. This is in contrast to sleep terrors now. Recall of sleep mentation is immediate and clear, and one or both of the following. Delayed return to sleep after the episodes, occurrence of episodes in the latter half of the habitual sleep period, again, because there's more REM in the second half of the night. 10 to 50% of children ages 3 to 5 will have nightmares severe enough to disturb their parents. There's no sex difference. Nightmares peak around ages 6 to 10. 50 to 80% of adults report at least an occasional nightmare. There's a female preponderance here. However, only 2 to 8% of the general population have recurrent nightmares. There is a strong association with psychopathology and nightmare disorder. Nightmares beginning within 3 months of trauma occur in 80% of PTSD patients. 50% of PTSD cases will resolve, so they won't meet clinical criteria anymore after 3 months, but post-traumatic nightmares can be lifelong. Predisposing factors for nightmares and PTSD include female sex, low socioeconomic and education levels, prior psychopathology. Interestingly, nightmares and acute stress disorder or post-traumatic stress disorder can also occur in non-REM sleep, in addition to REM sleep. Nightmares can lead to sort of a vicious cycle here where people will avoid sleep, it'll lead to sleep deprivation, and then they'll have a REM rebound, again, like the slow wave rebound we talked about, when they do sleep, which can lead to more bizarre and intense dreams, leading to insomnia and daytime sleepiness. Many medications out there can promote nightmares, including ones that act on neurotransmitters in the brain that are involved in sleep, but also over-the-counter medications and blood pressure medications. A lot of medications can cause this. So this is Pinhead from Hellraiser, another person you might see in your nightmares. Treatments, generally it's reassurance. If treatment is needed at this point in time, the gold standard is cognitive behavioral therapy. Particularly this image rehearsal therapy is really in vogue right now. And this involves the person suffering from nightmares writing down in detail the nightmare the next morning, but changing the ending so it's a positive ending and they have control over the situation. And then they are to rehearse this narrative. They read it to themselves. They say it out loud multiple times over the course of the day, and it is very effective. There are medications that can be helpful too, such as alpha blockers, for example, prazosin, and these sort of dial down that autonomic nervous system, kind of tell the brain to calm down. Cataphrenia, this is also known as sleep-related expiratory groaning, defined as a history of regularly occurring groaning or related monotonous vocalizations that occur during sleep. Or, on a sleep study with respiratory sound monitoring, there is characteristic respiratory dysrhythmia, which means irregular rhythm, predominantly or exclusively in REM sleep. This is very rare. Only about 0.5% of all sleep patients presenting to a large sleep clinic will present with this complaint. It usually occurs during the later REM sleep cycles. It is often brought to medical attention by a disturbed bed partner, family member, or roommate. And there's usually periodic bradypnea, which is slowing of the respiratory rate, associated with this during REM. You see a pattern of deep inspiration followed by protracted exhalation with a monotonous vocalization. Let me show you a video of this. It just occurred to me that it's probably a good case to be made based on this for cohabitation before marriage, because you probably wouldn't want to end up with someone who had this problem, especially because there's no cure. And we're going to talk about sleep enuresis, which is bedwetting. This is a picture from Iguazu Falls from the Argentinian side, and I was fortunate enough to visit there in the summer of 2009. Very beautiful. Sleep enuresis, defined as either primary or secondary. Primary, ages greater than 5, recurrent involuntary voiding during sleep 2 or more times a week. And the patient has never been consistently dry during sleep. Secondary sleep enuresis is defined as that the patient had been consistently dry for over 6 months. So in primary sleep enuresis, the individual fails to arouse from sleep in response to bladder sensation or fails to inhibit a bladder contraction. These are both developmentally acquired skills. A small proportion of cases lack the normal increase in vasopressin, which is an antidiuretic, so it helps us reabsorb water at the kidney. This hormone is normally put out during sleep. And so some people lack this response, which leads to high urinary volume, which can exceed bladder volume and cause a contraction. Psychosocial factors are actually relatively rare in kids with primary sleep enuresis, although there are increased rates of enuresis in kids with ADHD and who come from disorganized family situations. These kids tend to be deep sleepers. Secondary sleep enuresis stems from a medical problem. You can have an inability to concentrate urine, such as diabetes, increased urine production from excessive diuretics, caffeine is a diuretic, urinary tract pathology, chronic constipation and encopresis, which is uncontrolled bowel movements during sleep, neurological problems such as seizures, our old friend obstructive sleep apnea again, psychosocial stressors come into play here, parental divorce, neglect, abuse. It's the prevalence of enuresis. As you can see that here there's a high genetic factor here. So if both parents were bedwetters, 77% chance that their children will be bedwetters. 44% if one parent was. And actually some of the genetics of this have been worked out. There have been areas identified on chromosomes 22q, 13q, and 12q that correspond to predicting whether someone's going to be a bedwetter. Treatment, well, there's a 15% per year spontaneous cure rate. So most of these kids will grow out of it. As I said, it's a developmentally acquired skill. If treatment is needed, usually behavioral therapies are attempted first. Scheduled awakening, so a parent waking the child up, having them void during the night, or an alarm system where there's a circuit that goes underneath the child, and if there's any wetness that sort of shorts the circuit and causes a bell to go off, and the bell helps condition the child to control the bladder. Sometimes we use medications, and we always try to identify the underlying cause and treat it in secondary enuresis. So I put this picture up here because the most important thing about this, really in terms of any implications for the child, is how the family responds to it. So family needs to be very supportive and reassuring because it really can take its toll on children's self-esteem. In conclusion, I want to thank you for your attention. I want you to take away, if only one thing, that these disorders are very common and they have a lot of different ways of presenting. In fact, I have a video of a man who was named Best American Ever in a 2003 BBC online poll. I have a video of him exhibiting parasomnia. And this is a man that beat out Abraham Lincoln, Martin Luther King Jr., okay? Thank you for staying awake. I want to thank Mindy Ferland for inviting me over to speak, and especially Dave Vidru, who helped me out incredibly with the videos and the technology here, and of course Will Ferrell and John C. Reilly, Homer J. Simpson for aiding everyone's education. I think, do we have some time for questions? Okay. Okay, the question, did everyone hear that? How do you distinguish between restless leg syndrome and periodic limb movement disorder? I can't tell you how great of a question that is. I have all sorts of people who come into my clinic and say, I had a sleep study, and they said I was kicking my legs and told me I have restless leg syndrome. Wrong. Restless leg syndrome is a clinical diagnosis. It's based on your symptoms, like we talked about in the very beginning. Those feelings in your legs with the urge to move them around, worse at night, temporarily improved with movement.
Does sleep paralysis have to do with what you said about REM paralyzing your muscles?
Yeah, sleep paralysis is another REM parasomnia. Some people consider it parasomnia. It's actually, it can be a feature of narcolepsy too. It can just occur isolated, where it's called isolated sleep paralysis. This occurs in REM, and it very much is related to the physiology behind REM. Other questions? Wow. Okay, I was really thinking someone was going to ask me something that I have no idea about, so I guess I get off scot-free. Thanks for your attention.